Greetings and welcome, everyone. Thank you so much for joining us today for the fourth week of this year's HIV Prevention and Education Virtual Summit. My name is Kyle Shavasta, the Public Programs Manager here at the Community Health Training Alliance, a education and training program of Philadelphia Fight Community Health Centers. We have been learning so much this whole month about the issues that impact people living with HIV and how we can better provide care and service delivery. And today is going to be no different. Now, before I hand it over to today's speakers, I just want to go over some brief house rules. The chat is disabled, but if you have any questions, please place them in the Q&A box found below. We'll facilitate all questions at the end of today's presentation. Today's presentation is being recorded, and you can view this one along with all of our other presentations on our YouTube channel. Once the webinar is completed, a screen will pop up, and I'm just going to be asking you to take a brief survey. Just take it, let us know how we're doing, so we can continue to do all these wonderful webinars. So with us today, we have Wahome from AIDS Care Group, Alexandra Dongala from Philadelphia Department of Public Health, and moderating today we have Nicole Johnson, also from the Philadelphia Department of Public Health. Today they're going to be presenting a webinar entitled A Collaborative Effort to Address and Reduce HIV Disparities Among Black Women in Southeastern PA. Thank you so much, everyone, for being with us today. And with that, the floor is yours.
Good morning, everyone, and thank you for joining us. My name is Nicole Johnson, and I'm going to go ahead and start sharing my screen. So again, good morning, and thank you for being here. This is a collaboration between the Black Women's First Health Initiative with HRSA, and our cohort is our Southeastern Pennsylvania cohort. Our cohort includes, as you may have read, AIDS Care Group, Access Matter, and Philadelphia Department of Public Health. My name again is Nicole Johnson. I'm the coordinator of the SHE program, a new program from the city of Philadelphia designed to reduce healthcare disparities for Black women living with HIV. I will be your moderator today. Women account for 1/4 of people living with HIV in the US. Over 3/4 of these women are African-American and Latino women. African-American women have the highest rates of new infections of HIV, which is 16 times higher than that of non-Hispanic white women. African-American and Latino women represent less than 1/4 of the US women's population. Yet they account for 80% of the new HIV diagnosis for women in our country. Because of this, Health Resource and Service Administration, known as HRSA, introduced SPENS funding under the Improving Care and Treatment Coordination, focusing on Black women with HIV. Funding was awarded to 12 sites throughout our country, and today we are 3 of those sites represented here. Our sites are here to make sure that we are able to help with this fight and ending the epidemic, and the HIV epidemic. Our site funding was awarded through 3 years of funding for design, implementation, evaluation for the use of bundled intervention for Black women. Bundled interventions are a group of evidence-based informed practices put into a package that will be implemented together that produces better health outcomes, when delivered together than they would if they were delivered separately. Bundled interventions will address socio-cultural and health disparities, expand delivery and utilization of comprehensive HIV care and treatment services, provide support and continuous engagement in care, and improve health outcomes in a culturally sensitive and respectful manner. These programs were created as part of the Ending the Epidemic Plan for America. This 10-year initiative, beginning in 2020, seeks to achieve the important goal of reducing the new HIV infections in the United States fewer than 3,000 per year by 2030. To achieve these goals, programs align our efforts with the Ryan White Statute and Practice Guidance to ensure that people with HIV are linked to care, are retained to care, and have timely access to treatment, and we support their needs. Those needs sometimes are mental health and substance disorders to achieve viral load suppression. In Philadelphia, Delaware County, Chester County, Montgomery County, Bucks County, and Lancaster, they are the most populous in the state of Pennsylvania. The population is greater than 500,000. In Pennsylvania, the HIV epidemic occurs in these urban areas. They are 62% of the incidents and cases of new diagnosis of HIV in Pennsylvania. Among persons newly diagnosed with the disease in 2017, 86% were linked to medical care within the first month of their diagnosis. I'd like to now introduce our speakers for today. Our speakers are a part of our cohort that received funding for fighting the HIV epidemic for Black women living with HIV, and we're specifically in the Southeastern Pennsylvania region. Today, our first speaker will be Alexandra Dongala. She is passionate about educating others regarding their sexual health, wellness, and body and reproductive rights. This is evident with her work as the assistant coordinator for the PrEP program with the Philadelphia Department of Public Health. She services all 8 of our health centers. She is a graduate of Emory University, where she obtained her MBA in behavioral health sciences and health education. Currently, Alex is, when she's not fully focusing on her PrEP responsibilities, she allows us time in our SHE program. And she helps me with all of our communication needs, as you will see today. A fun fact about Alex, she is a proud plant mom. Also today, we will have Wahome, and she is a data manager at the AIDS Care Group and serves the co-principal investigator on the peer linkage and retention program for women of color living with HIV and AIDS. While obtaining her MPH, her Master of Public Health in Epidemiology from Drexel University, Mo was a keen contributor in navigating the African Health Diaspora Initiative and transforming it into a fully functioning program, conducting testing and linkage to care for Black immigrants to the city health centers. Mo is passionate about African health and development and using her art to engage the youth in health discussions. She directed and was featured in a documentary focusing on healthcare utilization among first-generation Black immigrants. Mo continues this important work as the principal investigator of the AIDS Care Group's Her Suspends Initiative, Black Women's Health Initiative in Chester, Pennsylvania. And a fun fact about Mo, she's a pretty competitive ping pong player, so watch out. So thank you for joining us. Alex?
So I just want to give you a quick snapshot of our ambulatory health services, which is the largest safety net provider of primary health care services in Philadelphia. As of 2020, we have about 80,000 patients, 8 federally qualified health centers, and FQHC lookalikes. Our primary goal is essentially to improve linkage to HIV primary care, but also retain patients into care. Some of our services, we have a plethora of services that we do provide, such as COVID-19 testing, vaccination services, primary adults, pediatric medical care, dental services, laboratory, pharmacy, radiology, family planning, and etc. Next slide, please. All right. So our ambulatory health services is essentially a network of 8 neighborhood-based health centers, 1, 2, 3, 4, 5, 6, offer a full range of co-located medical and support services. As of now, we have about 1,000 patients living with HIV, with the majority being of African or Black descent at 84%, white at 8.3%, Hispanic, Asian, and Pacific Islander, rounding it up at 0.2%. And the majority of that population is comprised of male population at 63% and females at 33%. Our biggest age range of those patients with HIV are between the age of 45 and 64 at 57%. Followed by the 25 to 44 age range folks at 28%. But we're also seeing a rising populations of 65 and older currently living with HIV. And then rounding up 13 to 24 at 2.6%. 72.1% of patients are currently living below 100% of the federal poverty level. Next slide. And okay, so we conducted a pilot of our SHE program, Sister and Health Equity, where we were actually trying to figure out our survey instruments, because part of the program is that comprehensive assessment will be conducted at different time points. So baseline upon enrollment, 6 months after enrollment, at the conclusion of participation, 12 months after enrollment, or 6 months after the conclusion of the project. And we pilot tested with 16 participants, and we found that our age range is between 24 and 72 with a mean age of 52. And of those 16 piloted participants, 5 of them were from outside of the US, 5 considered themselves caregivers, whether they were considered children or other adults that they cared for. 11 of the 16 were unemployed. 7 of them had less than a high school diploma. And 5 were uninsured, and 6 had experienced housing instability. Next slide, please. So to be part of the SHE program, right? So the SHE program is designed as a 6-month intervention for eligible participants, and eligibility criteria are as follow. Identify as Black, Latin, so non-Latinx, US, and non-US born. Identify as female, cis, or transgender, transgender female. It's not listed here, but 18 and older. Is a super utilizer of care, and that is defined as 2 emergency department visits, 1 hospitalization within the past 12 months, also, or 1, medical and social needs causing struggle to adhere to the HIV care continuum. So intermittent, so a patient who may not necessarily follow or take their HIV medicine consistently. 2 miss scheduled HIV primary care appointments within 12 months. And those patients who are loosely engaged or lost to care. So those patients who sort of come in and out of care whenever they feel the need to. Next. All right. So I also want to add that all participants will receive enhanced medical and behavioral health support, beginning with a comprehensive in-home assessment by a core team of a project nurse and a licensed clinical social worker. Can you go back, please? All right, so as part of the SHE program, we just want to make sure that we hit some of those goals. So improve the health outcome of Black women, obviously, remove barriers and stigma, making sure that they are comfortable, build trust through trauma-informed care, provide health and wellness education, enable access to digital tools for patient connection because hello, COVID, but also make a concerted effort to reach Black, cisgender, and transgender women of Hispanic or non-Hispanic ethnicity. Next one, please. And we will accomplish this by providing bundled intervention. I think Nicole had a really good description of what bundle interventions are, but they are described as DUS for us: the red carpet care, trauma-informed care, and prime sister circle. The red carpet care is essentially an intervention in which enhanced medical and behavioral health services are delivered to patients with enhanced coordination of cares. And that one, as mentioned, is led by our nurse practitioner. I want to shout them out, Tawana Stokes, and our social clinical worker, Jessica Gottlieb. And then we also have the trauma-informed care, which is essentially creating a care environment and care based on the recognition of trauma and its impact on health and engagement in care, right? So looking at ongoing staff training and also giving the skills to trauma-informed center-based like champions that we call like shepherds. It's a funny note that we're providing to those staff who are basically being trained in trauma-informed care. And then we have lastly the Primetime Sister Circle, which is essentially a 12-week culturally responsive program supporting and nurturing women's self-efficacy. It is intended to reduce health disparities and improve outcome. And some of that could be nutrition, eating well, exercising, finding ways to deal with trauma and so forth. So that those are essentially workshops that are being led by some of our partners, which is what the Black Women's Health Alliance is leading that portion of our project. And then we're ending with some COVID-19 service provision that we have been forced to do this year, where we have implemented virtual visits and telemedicine, physical distancing of patients in waiting rooms. That is also slowly phasing out as the outside is opening up, but we do have kept our plexiglass barrier installation at all patient check-in stations, PPA provisions. So patient, if they need a mask or gloves, those are provided to them. We have shifted from a walk-in model to an urgent care model. And then we have a front door triage and screening, where when you come into your when you come into our health centers, your temperature is taken and you're going to ask about, where have you been? And just, if you've been exposed to COVID-19 and so forth. Extensive patient outreach, which is done by our, care team, reaching out to patients just to see what they need, what could be help with like food and transportation assistance, but also providing patient education, looking at COVID safety, perceived illness risk due to their HIV status. I think that's it for me. I do want to add that the, well, we already said it, but the project is funded by HRSA. And we're also to think that Pennsylvania, Mid-Atlantic AETC, the Black Women's Health Alliance, for partnering and implementing the SHE program. But that is me. That is all, I believe.
Good morning. My name is Wahome, and I serve as the principal investigator for the Black Women's Health Initiative. And we're based out of Delaware County in Chester, and we have another clinic in Sharon Hill. So I'll give a brief overview of our program. Going back to what Nicole said about some of the more populous state counties in Pennsylvania. We're located in Delaware County, and looking at the annual diagnosis of HIV between 2016 and 2018, we had one of the highest after Philadelphia. So we're in a resource poor community, but we do service a lot of men and women living with HIV in Delaware County. Next slide, please. So this is a brief overview of where we're located. We're right outside Philadelphia. So we do have two clinics, one in Chester and one close to Darby area. So we do see quite a bit of residents from Southwest Philly as well. And we were incorporated in 1998 to serve a medically underserved region. Mostly in Chester, we started out in Chester and expanded to Sharon Hill. Some of the services that we provide are HIV medical care. We have a dental clinic as well. We do have C treatment, screening and treatment for STIs. We have a PrEP program, and we also do behavior and psychosocial services. We first received Ryan White funding in 1999, and now we're funded through Parts A, B, C, D, and now SPINS for the last couple of years. Other services, we have our in-house pharmacy, and we have the option for delivery for our patients, or they can come pick them up at either clinic. We have an outreach team, and we provide transportation as well for those in need. And we have a food and wellness program, which I'll talk about later. And we do provide case management in partnership with Action Wellness. And some of their case managers are able to come to our office and see our patients. Next slide. So our patient population, we see about 966 patients living with HIV. We have an additional 600 that we're seeing for Hep C, PrEP, STDs, and opioid use. And this could be duplicate and non-duplicate patients as well. On average, we see about 80 to 90 new patients every year. 82 patients identify as ethnic and racial minorities. About 40% are women, and we also see a large immigrant population. These are primarily West African patients. We do have a large patient population that has Medicaid or Medicare or uninsured. And we have about 10% that report unstable housing as well. Next slide. So we wanted to create this initiative when we saw the opportunity for funding. And this was largely informed based on our unmet needs that we found. We had just completed another SPINS program from 2016 to 2019. And we utilized peers, and we found that the top 5 frequently reported unmet needs were transportation, housing needs, social benefits, medication assistance, and substance use and mental health treatment. And other barriers that were also reported but not as high in frequency were stigma and lack of trust with the medical system, and lack of childcare, dealing with other co-occurring conditions, and incarceration histories as well. And also, as the data showed, Delaware County has the 3rd highest number of cumulative HIV disease across the state. So we thought, given all this unmet needs, we thought bundling the different interventions would be the best way to sort of address some of these things and help with the Ending the Epidemic initiative. Next slide. So we started out this program around April with enrolling people. So the criteria for eligibility would be those who are over 18 and identify as Black women. They have to be out of care for 6 months or more. So not had a lab or a medical visit in 6 months. Newly diagnosed within 12 months, at risk of falling out of care. And this is defined as more if they've missed 3 or more appointments within 6 months, have a history of relapse, recent history of incarceration or domestic violence history. Next slide. So our bundled intervention incorporates red carpet care. As Alexandra mentioned, it's just support services that can help get patients linked to care. So this includes transportation, food insecurity, linking people to a housing counselor to sort of find affordable housing. We also utilize enhanced outreach and linkage through community health workers. And this we found helpful from the last SPINS project because we utilized peers, and that was helpful in reminding patients for their medical visits, calling them about taking their medication. So we incorporated this as well. And we lastly use the trauma-informed care, and we link clients who are in need to a clinical psychologist who's Black and also specializes in women's health. And so that is helpful as well. Next slide. So desired outcomes for our bundled intervention, our goal is to link and retain 90 to 100 Black women in quality HIV care. And this is over the span of 3 years. And so far we have 14 women. So we hope to keep the momentum going. We hope to adopt red carpet care as part of multidisciplinary efforts in the care continuum, and hoping that this will over time reduce barriers to care. And lastly, we hope to engage more women in trauma-informed care and just address some of these foundational stressors that can impact them accessing care, and just to empower more women in managing their health. Next slide. Some of the challenges that we faced with initiating the program obviously was due to COVID. We did scale down in office and had telehealth for non-emergency visits. And we did a lot of check-ins over the phone every 10 days for patients. For those that needed food, we were able to drop off food bags for some of the patients that live in like food deserts or have issues with transportation. So that was great because our food program grew a lot last year because we got a lot of donations from supermarkets and food banks. But we also have plexiglass. Similar to the Philly Health Department, we had similar triage and providing PPE for patients that needed it. But we have since reopened as of this month, and we're starting to see way more patients coming in, and we're doing more outreach. So we're hoping that with having our staff vaccinated and encouraging more patients to get vaccinated, that we'll start to see more women back in care. And that's all I had for our program.
Thank you, Mo and Alexandra, for your information. As I said before, we are 2 of 3 sites. Access Matter is also a part of this. And although they could not be here today, they want to share their information with us. So their bundled interventions include a Stay Connected for Health, which is a warm greeting by clinical staff, brochures and posters, and of course, one-on-one sessions with a retention specialist to really help foster relationships and help with women and their ability to maintain health care for their HIV. Their second is Taking Care of Me, is a video vignette exploring disclosure, medication initiation, adherence and retention to care. This also played in their waiting room while the patients wait for their visits. Their third intervention is We Care, and it's Building Healthy Relationships, a 6-week group session designed to assist Black women living with HIV with developing identifying stress, developing coping skills, disclosure, and building safer and healthier relationships. So their Deputy Director is Nicole Johnson, and her email is there, as well as Allison Hurstman, and she can also her email is also there. So we thank you for taking the time to hear us today, and we appreciate you coming. And again, I'd like to apologize for all of my snafus. My teammates were excellent, and if you have any questions, we would like to take them now.
Awesome, awesome. Thank you so much for providing us with that, all this pertinent information. And I just want to thank you, Mo, Alexandra, and Nicole for supplying us with a wonderful presentation. And, you know, doing the work that you all are doing is vital, and then sharing it on a wonky platform like Zoom has its challenges. So thank you for sharing it with you know, knowledgeable, you know, sharing this and sharing it with grace. So I just want to uplift you all today and say thank you so much. And thank you to our audience as well for joining us today and all month long. So please put your thinking caps on, because this is your time for Q&A. So any questions you may have for today's presenters, just put it in the Q&A box below. So it looks like we have a note from someone. Thank you, Alex, Mo, and Nicole, for this very informative webinar. Great job, thumbs up. And they put a little thumbs up emoji in the Q&A box. I don't know how they did that, but that's something you learn every day. So while our audience kind of thinks of some questions, I actually just want to say, I think the bundled care approach is wonderful. And I was particularly taken by the terminology, the red carpet care, which is, I think, a great way to describe that holistic approach to care. What was kind of the rationale behind calling it red carpet care?
Well, we found there's many different iterations of red carpet care. And as you can see, AIDS Care Group and Philadelphia Department of Public Health, we have our own versions of it, but they're all designed to foster a closer and more intensive type of care on top of what we're already providing. Mo, your thoughts on that?
Yeah, I think that terminology was coined by some researcher, I can't remember his name, but so I think it's just a terminology to cover all the support services that can help with linkage and retention.
Awesome, awesome, thank you for that. So it looks like we have some questions. Someone asked, what hindrance do you anticipate coming up against in the pursuit of your mission? And this is to all panelists.
I can share. I guess we had a slow start, and it's largely due to COVID, and like part of the team being working from home and conducting outreach, but we can't physically go to people's homes, and or people having changed for the people that have fallen out of care, they might have moved or they might change their phone numbers. So finding eligible patients can be challenging when you don't have the correct information, and because of the pandemic. But we're starting to see more patients, so hopefully some of those will be like not.
I think on our end, maybe Nicole can add to it. I think I'm looking primarily into the prime time sister circle, like patients maybe not comfortable with sharing a space with other patients who share the same status, and then just because they just don't want other people to know. And also Philly is kind of small. It's big, but yet small. So I'm being uncomfortable with that. I think that our team has been really good at creating ties with patients so that they feel comfortable coming back. But I don't have like a direct, I guess, interaction with the patient. So I don't know if that's a true assessment of how a patient feels about the care that they're currently receiving. But also, I mean, I would also add that like all our patients really love our providers, especially if they are being provided by Dr. Kwakwa. Some of them are like in love with her and that they follow her where she goes. So yeah, but in terms of like, struggle or like resistance, I can't think of anything.
I think that my answer kind of will answer the question that's in the chat. Also, question by Christine. Christine's question is about cisgendered women and their viral load suppression being lower than other groups. And I think that it also incorporates the same reason that we might find challenges or struggles with this program is that a lot of Black women are caretakers within our community. And being a caretaker means they often don't take care of themselves first. And in doing that, they don't necessarily go to the doctors the way they're supposed to. They don't think of themselves first. They don't eat healthily. But what we're finding is through our programs and the programs that we're partnering with is that when you help women to learn to take care of themselves, they usually have a better outcome for their whole family, not just them personally. And so that's what we're trying to do here. We're trying to work to have them learn to take care of themselves in a better way. And in doing so, it would increase the health and improve the health of their whole family.
Absolutely. Thank you for that. Thank you so much.
Yeah, to add to Nicole, I was going to say, to add to Nicole's point, part of the need for trauma-informed care also is just, I mean, there's been studies that show women who have trauma are less likely to be virally suppressed. And I think there's like a normalization of what trauma is. And so I think, that affects so many things like medication adherence. And so part of the bundled intervention is to help women, address the trauma and like adopt healthier skills, life skills, and life management.
Tremendous. Thank you. Thank you. We have a number of questions coming in, which is wonderful. Can you please speak to the initial assessments you did with participants to identify their needs? What was the process?
So I can speak to it because I I did that portion. So we had our survey as part of the baseline 6 month and 12 month survey that we were trying to sort of tune. And the process, well, let me just walk you through it. So they come in, we have a consent form, we go through the consent form, make sure that they, know what they are getting into. And then we have several questions on like demographics, but also like mental health. It also questions about, for example, within the past 12 months, were you struggling with having access to food? You'd be like, yes. Did you try to reach out and get access to food? And yes or no. And then I think the third question is, do you need help with accessing food? So those are like the questions we asked in terms of like determining their needs, but also looking at their mental health, asking about how do they feel ashamed of their status? Do they have a support system? Does anybody else in their family know about their status? So those are some of those questions that we could, once they've answered, we could pull out and just be like, all right, based on this, like how many participants, these are the needs that they're struggling with, and then reacting according to that. So, yeah. And also some of while doing the survey, like some patients wouldn't even would offer something or a need that it wasn't necessarily reflected within their survey. Like I had a patient who at the end, like she was like asking, or I was asking her, like, do you need any, like, I don't know, health related medical needs? And she's like, no. And then she's like, well, actually, yes, I need dental care. I was like, okay, so that I was able to put that in like a note, like this patient needs dental care, but also talking to the care team, Jessica and Tawana, and be like, oh, hey, just FYI, I finished the survey with her, but these are the extra needs that she needs help with. Was also helpful, because and then I found out that she didn't even tell them that she needed dental care. So I had to like call and be like, hey, I don't know if she's mentioned it, but these are the needs that she needs to be helped with. Oh, and also at the end, they also received like a gift card, because the survey is pretty long. It's about like an hour. With including the consent form, it's about an hour and a half. So they do get like a gift card every time you do that. And I think the gift card is what, 50, 20? Nicole is like shaking her head. I was like, wait.
Sorry.
25?
Our gift cards are staggered in value, because we know that it's more challenging as the program goes on to get people to want to sit down and take the evaluation. So we start off with a smaller amount, and then they go up with each one. So we have a total of 3 gift cards and 3 different amounts. But I think also, and even considering what bundled interventions to put into the program, part of it was just assessing the needs of our patients overall, and looking at which patients were struggling, assessing why they were struggling. Just knowing your patient sometimes can help you determine which interventions to decide to put into our program.
Wonderful, wonderful. And I liked the note about allowing the folks you were serving to inform the data collection. That's That's awesome. Thank you for that answer. We have a bunch more questions. Thank you for your presentation today. I'm wondering if you noticed any particular challenges for trans women in accessing your resources. Were they able to participate in spaces like the community support groups?
So for us, we have trans patient population within our health centers already. They already utilize our services. And so for us, it was just a matter in our enrollment process of just identifying patients that we thought could use the program. And in that, we did make sure that we included women of all genders that would want to participate. We gave them space to learn about the program and then determine whether or not they want to be a part of the program. Also within our program, we have an advisory board, and within our advisory board, we also have trans and cisgender women in our advisory board. So that also helps to inform us of how to go about recruitment, how to go about retention, and just talking to people who don't necessarily fit the criteria for our program, but are also still patients, so that we can get their feedback and understand of what our patients think, want, and need.
Wonderful.
We don't see a lot of trans women. Most trans women tend to go to Philadelphia for more resources because Delaware County doesn't have as many clinics that cater to that. But we did start a program not too long ago for trans care. So we're hoping to see way more than we have seen in the past.
Thank you. So we have a number more questions. How can your efforts in Philadelphia be modeled for other cities?
Well, that is the very nature of this program. The whole point of the Black Women's First initiative is to make sure that we are able to use this as a pilot. And through working this as a pilot, just with Mo's program and Access Matters program, is to just look at the interventions that we've chosen and determine after this pilot program is over, we assess how much of each intervention they received and then determine if them receiving this intervention and if the amount that they received it at, did it help improve their health care, their overall life. And if so, our hope is that anyone can take our program manual and recreate this program because that's the whole point of all of this.
Tremendous, thank you.
Yeah, from the last SPINS project that we had, they're pretty good with compiling findings and creating manuals that can then be replicated and shared with other Ryan White clinics. So yeah, so hers is pretty good with that. And we did create manuals for working with peers that was published last year. So I'm pretty sure after this program ends, we'll probably do the same thing and other clinics can pick up on such.
Excellent, excellent. We have a note from Christine. We noticed that if they have perinatally infected children, the children are undetectable. They will take meds while pregnant. They will make sure their partners are undetectable and still won't take their meds. It is very sad. Do you all have any notes or reflections upon that statement?
I know that we have a patient finding out very, very similar to that, in that she would get, like every time she would see her own HIV meds, she would get triggered by it. Like it would just like anxiety level. And if my understanding is that she worked with Dr. Kwakwa in sort of lessening that anxiety and also she had complication because she was not taking her medicine. But then because of the complication, was forced, I guess, to take her medicine. But that's only one patient that I can remember off the top of my head. That's pretty recent, but I'm sure that we'll come across more like patient who have like similar story. As of now, we've only completed our baseline survey with 4 patients, but that story hasn't at least been shared with us, but I'm sure it has happened, just we don't know.
We also find that some patients' partners don't choose to take medication. Alex also works for the PrEP program. So we have a very comprehensive PrEP program as well. But some patients' partners don't choose to use medication because that's their choice. Unfortunately, it's not ideal, but it is a choice. And people, unfortunately, they don't necessarily take care of their health the way we think that is best for them, but all we can do is provide the opportunity for them to have what they need to take care of themselves, to take care of their partners, and of course to take care of their children. And that's what we provide. We don't judge them. We just understand that that's where they are at this particular time. It's very hard living with HIV. It's a lifelong illness, and it's something that people find very difficult. And taking medication, like Alex says, is sometimes just a reminder of where you are. And that can be traumatic for people. And I think we need to give space for that, and that people and understand that people are sometimes dealing with this in their own way, and it's very difficult for them.
Wonderful. Thank you. Thank you for that. So Mo, with your patient population being mostly refugees, immigrants, and migrants, in terms of barriers to care, to what extent do limited language proficiency and lack of cultural awareness competency add to barriers to care?
That's a good question. One of our medical providers is African, and so a lot of patients tend to gravitate towards him just because he understands some of the cultural elements. And sometimes we utilize the phone translation services, but it's also limited in the amount of African languages that it has. So we've had some patients come with like a relative who's lived here longer and knows English and can help them navigate the healthcare system better than they can. We've had one of our peers is also working on this project as a community health worker, and she received a lot of training on cultural humility, so that helps in just how we deliver care to immigrants in comparison to US born women. And we do partner with, we had an African lawyer who we used to refer some of our patients that need help with paperwork and to her. So we're still trying to figure out best practices, but having a medical provider that can relate with some of the patients helps because he's able to help address some of the cultural elements that maybe not a lot of people would catch.
Awesome, awesome, thank you. What are the types of support systems for HIV positive Black women in Philadelphia?
There are a lot of systems to support Black women. There are a lot of different programs out there, particularly at the Department of Public Health. We do have this program for one. Also, a lot of our program is designed around helping to retain and keep patients engaged. If they find that they are having a problem being engaged, we have health system navigators that can help with them and get them to their appointments, make appointments for them, walk them through if they feel like they need that support. We also have medical case managers. Our case managers are there to help support them with needs that they may have outside of just their medical care. During the pandemic, they were able to help with finding food sources for our patients, also finding funding for housing, as well as they were the ones that were keen in providing our Lyft transportation services, not just to their primary care visits, but also the specialty visits if they needed it. So throughout our center, we have a lot of ways to support. And on top of that, we just have our great employees, our great staff are there to support our patients. I think sometimes it's difficult for people to think of the Philadelphia Department of Public Health, the 8 health centers, as good care. But it does provide really good care and really quality care for our patients. But I'm sure that Mo also has great support for Black women in the county as well.
Yeah, we do. We provide the services that I mentioned earlier. So they're not exclusive to Black women, but we do provide a lot of support services for all our patients, and our community health workers are Black women living with HIV, so they're able to serve as liaisons for the women and the medical care team, and they feel more comfortable telling them some things that they wouldn't tell the care providers, so we're able to capture all the needs. Having people that look like them, that have shared experiences, and that's been pretty helpful for us.
Wonderful, wonderful, thank you. And thank you for that question. So another question, does mental health services help address the various barriers the women are facing?
Yeah, I would say yes, definitely. Most of our patients do receive some type of mental health assistance. There are a few women who relapsed, just that was their coping mechanism. So we're getting them back into mental health support, just because things like that definitely impact accessing care, staying in care. So that's definitely part of the overall HIV care. And it's crucial for a lot of women that we see.
For us, it's part of our bundle intervention. As Alex mentioned before, we have a licensed clinical social worker who does psychosocial evaluations as one of our baseline evaluations for all of our patients in our program, as well as throughout just being that constant support there. And if they need further treatment as far as further counseling, she's there for that as well. She also does checks. She's doing checks for our patients periodically just to see how they're doing. But also, we find that, as Mo said, a lot of our patients do have needs in mental health care. And yes, it does help because, as I said before, they are going through something that is very traumatizing for them, and they need that support. Some people can't always identify when they need that support. And so that's why we kind of built it into our red carpet care program to kind of help them understand that. But at the same time, there are patients that do seek out that mental health component for themselves. And they find that when they utilize that, that they do better.
Awesome, awesome. So it looks like that's it for questions. Audience, thank you so much for asking really thoughtful and wonderful questions. And Nicole, Mo, and Alexandra, thank you for providing such great information on this program you all have been working on, and especially during the pandemic. Thank you, thank you, thank you. Thank you. I think webinars are always a challenge, even after a whole pandemic, you know, and doing all of this virtually. You all did your work virtually, I'm sure, for a whole year, and you all provided us with so much food for thought and so much vital information. So once again, Nicole, Mo, and Alexandra, thank you, thank you. And to our audience members, thank you for being wonderful and engaging with our presenters today. So with that, I hope everyone has a wonderful day, a wonderful end of the week, and take care and enjoy the weather, everyone. Thank you. Take care.
Bye-bye.
Bye-bye.
Thank you.